Hi everyone, welcome to my channel. In this video we are going to learn about internal capsule. We are going to talk about its introduction, shape, parts, constituent fibers, arterial supply and its clinical anatomy. Internal capsule. It is a compact bundle of projection fibers. It is a compact bundle of projection fibers. Projection fibers are the fibers of white matter that connect the cerebral cortex with the subcortical centers. Location: it lies between thalamus and caudate nucleus medially and the lentiform nucleus laterally. Internal capsule lies between caudate nucleus and thalamus medially and the lentiform nucleus laterally. Continuation of internal capsule. The fibers of internal capsule fan out cranially and form corona radiata. They condense caudally to continue as crus cerebri of the midbrain. The fibers of internal capsule fan out cranially to form corona radiata and the fibers condense caudally to continue as crus cerebri of the midbrain. It consists of ascending and descending nerve fibers which interconnect the cerebral cortex with the brainstem and spinal cord. It consists of ascending and descending nerve fibers which interconnect the cerebral cortex with the brainstem and spinal cord. Shape. In a horizontal section of cerebral hemisphere, the internal capsule appears as a V-shaped compact bundle with its concavity directed laterally. If we take a horizontal section of the cerebral hemisphere, the internal capsule appears as V-shaped compact bundle with its concavity directed laterally. Now let's see the parts. The internal capsule is divided into following 5 parts: anterior limb, posterior limb, genu, retrolentiform part and sublentiform part. Anterior limb lies between caudate nucleus and anterior part of lentiform nucleus. Anterior limb, it lies between caudate nucleus and anterior part of the lentiform nucleus. Posterior limb, it lies between thalamus and posterior part of lentiform nucleus. Genu, it is a bend between anterior limb and posterior limb with its concavity directed laterally. Retrolentiform part, it lies posteriorly behind the lentiform nucleus. Sublentiform part lies below the lentiform nucleus. The anterior limb lies between caudate nucleus and anterior part of lentiform nucleus. Posterior limb lies between thalamus and posterior part of lentiform nucleus. Genu is bent between anterior and posterior limbs. Retrolentiform part lies posteriorly behind the lentiform nucleus. Sublentiform part lies below the lentiform nucleus. Now let's see the constituent fibers of the internal capsule. It consists of motor and sensory fibers. Motor fibers are descending fibers, sensory fibers are ascending fibers. Motor fibers include corticopontine fibers, pyramidal fibers, and extrapyramidal fibers. Corticopontine fibers, they originate from the cerebral cortex of all the lobes. The corticopontine fibers arises from the cerebral cortex of all the lobes and they rely in ipsilateral pontine nuclei. This is a transverse section of pons showing pontine nuclei. From the frontal lobe to the pontine nuclei, frontopontine fibers. From the parietal lobe to the pontine nuclei, parieto-pontine fibers. From the occipital lobe to the pontine nuclei, occipito-pontine fibers. From the temporal lobe to the pontine nuclei, temporopontine fibers. The frontopontine fibers are most numerous. They pass through anterior limb, genu, and posterior limb. Frontopontine fibers are most numerous and they pass through anterior limb, genu, and posterior limb. Parieto-pontine and occipito-pontine fibers. Parieto-pontine and occipito-pontine fibers pass through retrolentiform part of the internal capsule. Temporopontine fibers pass through sublentiform part. Frontopontine fibers pass through anterior limb, genu, and posterior limb. Parieto-pontine and occipito-pontine fibers pass through retrolentiform part. Temporopontine fibers pass through sublentiform part. Corticopontine fibers relay in the ipsilateral pontine. The fibers arising from the cerebral cortex of all the lobes relay in the ipsilateral pontine nuclei. The fibers arising from the pontine nuclei cross the midline to relay in the cortex of opposite cerebellar hemisphere, thus forming corticopontocerebellar pathway. The corticopontocerebellar pathway is most recent in development and is best developed in the man. Pyramidal fibers. We have seen about corticopontine fibers. Now let's see about pyramidal fibers. They arise in the cerebral cortex and relay in the brainstem and spinal cord. They are of two types: corticonuclear fibers, corticospinal fibers. Corticonuclear fibers from the cerebral cortex to contralateral motor nuclei of cranial nerves which innervate the head and neck muscles. From the cerebral cortex to the contralateral motor nuclei of cranial nerves which innervate the head and neck muscles. They occupy the genu of internal capsule. The corticonuclear fibers for head and neck muscles occupy the genu of internal capsule. Corticospinal fibers from the cerebral cortex to contralateral anterior horn cells of the spinal cord, which innervate muscles of upper limb, trunk, and lower limb. Corticospinal fibers from the cerebral cortex to the contralateral anterior horn cells of the spinal cord, which innervate the muscles of upper limb, trunk, and lower. The corticospinal fibers occupy the anterior two-thirds of the posterior limb. The fibers for upper limb are present most anteriorly, followed by fibers of trunk, and then followed by the fibers of lower limb. Corticospinal fibers form several discrete bundles in the anterior two-thirds of the posterior limb. The fibers for the upper limb are most anterior, followed by the trunk, and then the lower limb. First upper limb, then trunk, and then lower limb. Extrapyramidal fibers. They arise in the cerebral cortex and relay into the subcortical gray matter belonging to the extrapyramidal system. Example: red nucleus, corpus striatum, substantia nigra, and so on. Corticorubral tract. These are extrapyramidal fibers. Motor fibers include corticopontine fibers, pyramidal fibers, extrapyramidal fibers. Pyramidal fibers include corticonuclear fibers and corticospinal fibers. Corticopontine fibers include frontopontine fibers, paretopontine fibers, occipitopontine fibers, temporopontine fibers. Frontopontine fibers pass through anterior limb, genu, and the posterior limb. Paretopontine and occipitopontine fibers pass through retrolentiform part. Temporopontine fibers pass through sublentiform part. Pyramidal fibers include corticonuclear and corticospinal fibers. Corticonuclear fibers for the head and neck occupy the genu of the internal capsule. Corticospinal fibers form several discrete bundles in the anterior two-thirds of the posterior limb. The fibers for upper limb most anteriorly, then followed by the trunk, then followed by lower limb. Extrapyramidal fibers connect the cerebral cortex with the subcortical gray matter of the extrapyramidal system. Now let's see about sensory fibers. Sensory fibers. Most of the sensory fibers are received by thalamocortical fibers. Most of the sensory fibers are thalamocortical fibers. The fibers radiate from the thalamus in different directions to reach the cerebral cortex, forming thalamic radiation. The fibers radiate from the thalamus in different directions to reach the cerebral cortex, forming thalamic radiation. The fibers form thalamic radiation as follows: anterior thalamic radiation, superior thalamic radiation, posterior thalamic radiation, and inferior thalamic radiation. Anterior thalamic radiation. The fibers are directed anteriorly. The fibers are directed anteriorly. They connect the anterior and dorsomedial nucleus of thalamus to frontal cortex. They connect anterior and dorsomedial nucleus of thalamus with the frontal cortex. Anterior thalamic radiation, the fibers are directed anteriorly. They connect the anterior nucleus and dorsomedial nucleus of thalamus with the frontal cortex. Superior thalamic radiation. The fibers are directed superiorly. The fibers pass from ventral group of thalamic nuclei to sensory cortex of frontal and parietal lobe. They connect ventral group of thalamic nuclei with the sensory cortex of frontal and parietal lobes. Posterior thalamic radiation. The fibers are directed posteriorly. The fibers are directed posteriorly. The fibers pass through retrolentiform part. The fibers of posterior thalamic radiation passes through retrolentiform part. They connect lateral geniculate body to primary visual area of the occipital lobe, forming optic radiation. Posterior thalamic radiation fibers connect the lateral geniculate body with the primary visual area of the occipital lateral geniculate body visual area. Visual. Remember it as light. L. L. Lateral geniculate body light visual area. The fibers of posterior thalamic radiation connects the lateral geniculate body with the primary visual area of occipital lobe. Occipital lobe is present posteriorly. The posterior thalamic radiation connects the lateral geniculate body with the visual area of the occipital lobe. These fibers pass through retrolentiform part of internal capsule. Inferior thalamic radiation. The fibers are directed inferiorly. Fibers pass through sublentiform part. The fibers pass through sublentiform part. They connect medial geniculate body with the primary auditory area of temporal lobe as auditory radiation. The fibers of inferior thalamic radiation connect the medial geniculate body with the primary auditory area of the temporal lobe, forming auditory radiation. Let's revise the sensory fibers. Anterior thalamic radiation. The fibers are directed anteriorly. They connect the anterior and dorsomedial nucleus of thalamus with the frontal cortex. Superior thalamic radiation. The fibers are directed superiorly. They pass from ventral group of thalamic nuclei to the sensory cortex of frontal and parietal lobes. Posterior thalamic radiation fibers are directed posteriorly. These fibers connect the lateral geniculate body with the primary visual area of the occipital lobe. They pass through retrolentiform part. Inferior thalamic radiation. The fibers are directed inferiorly. They connect the medial geniculate body with the primary auditory area. They pass through sublentiform part. Now let's see the arterial supply of internal capsule. The arterial supply is of great clinical significance due to high incidence of vascular lesions. Various arteries supplying the internal capsular, medial and lateral striate branches of middle cerebral artery. Basilar artery, it gives rise to posterior cerebral arteries. This is posterior communicating artery, internal carotid artery, anterior cerebral artery. This is anterior communicating artery, middle cerebral artery, anterior choroidal artery. This is middle cerebral artery arising from internal carotid artery. Medial and lateral striate branches of middle cerebral artery supply the internal capsule. One of the lateral striate branches is larger and more frequently ruptured. It is often termed Charcot's artery of cerebral hemorrhage. One of the lateral striate branches of middle cerebral artery is larger and is more often ruptured. It is termed as Charcot's artery of cerebral hemorrhage. It enters the anterior perforated substance and supplies the posterior. The branches of middle cerebral artery supplies the posterior limb. Striate branches of anterior cerebral artery. One of these striate branches is larger and takes a recurrent course. It is often termed recurrent artery of Huebner. It arises just proximal to anterior communicating artery. It supplies genu and anterior limb of the internal capsule. Striate branches of anterior cerebral artery supply the internal capsule. This is internal carotid artery giving anterior cerebral artery. The striate branches of anterior cerebral artery supply the internal capsule. One of these striate branches is larger and often takes a recurrent course. It is termed as recurrent artery of Huebner. It supplies anterior limb and genu of the internal capsule. Some direct branches of internal carotid artery supply the genu. You can see here this is internal carotid artery, direct branch from the internal carotid artery supplying the genu. Branches of anterior choroidal artery. They supply posterior one-third part of the posterior limb, sublentiform part and retrolentiform part. Branches of anterior choroidal artery supply the posterior one-third of posterior limb, sublentiform part and retrolentiform part. Central branch of Anterior choroidal artery supplies the sublentiform part. Branches of posterior cerebral artery supplies retrolentiform and sublentiform. Posterior cerebral artery. Branches of posterior cerebral artery supplies sublentiform part and retrolentiform part of the internal capsule. Medial and lateral striate branches of middle cerebral artery supplies the posterior limb. One of the lateral striate branches of the middle cerebral artery is often ruptured and it is termed as Charcot's artery of cerebral hemorrhage. It supplies posterior limb. Striate branches of anterior cerebral artery. One of these striate branches is larger and often takes a recurrent course. It is termed as recurrent artery of Huebner. It supplies the anterior limb and genu of the internal capsule. Some direct branches from the internal carotid artery supplies the genu. Anterior choroidal artery supplies posterior one-third of the posterior limb, sublentiform part and retrolentiform part. Branches from posterior cerebral artery supplies sublentiform part and retrolentiform part. Clinical anatomy. Now let's see the clinical anatomy of internal capsule. Vascular lesions of internal capsule are common. Lesions may result from thrombosis or rupture of one of the arteries supplying the internal capsule. The lesion may result from thrombosis or rupture of one of the arteries supplying the internal capsule. Hemorrhage commonly occurs due to rupture of Charcot's artery. Hemorrhage commonly occurs due to rupture of Charcot's artery, which supplies the posterior limb. The Charcot's artery is a branch of middle cerebral artery. It supplies posterior limb. In the posterior limb, corticospinal fibers for the upper limb, trunk and lower limb muscles are present and extrapyramidal fibers are present. Due to involvement of Charcot's artery, there is lesion in the posterior limb. This results in spastic paralysis of opposite half of the body. It occurs due to involvement of pyramidal and extrapyramidal fibers for upper limb, trunk and lower limb on the opposite side. Involvement of recurrent artery of Huebner due to thrombosis or rupture results in paralysis of face and upper limb on the opposite side. Because of involvement of corticonuclear fibers in the genu and adjacent pyramidal fibers in the posterior limb for the upper limb. When there is involvement of recurrent artery of the Huebner, it affects the anterior limb and genu. The corticonuclear fibers for the head and neck muscles are present in genu. So the head and neck muscles are affected, and adjacent to the genu in the posterior limb, the upper limb muscles also may be affected. Because of involvement of corticonuclear fibers in the genu, there is paralysis of face, and due to involvement of adjacent pyramidal fibers in the posterior limb for the upper limb, there is paralysis of upper limb muscles on the opposite side. Lesions of posterior one-third of the posterior limb, sublentiform and retrolentiform parts occur due to thrombosis of anterior choroidal artery, a branch of internal carotid artery. This leads to visual and auditory defects. When there is involvement of anterior choroidal artery, it affects posterior one-third of the posterior limb, sublentiform part and retrolentiform part. The fibers of posterior thalamic radiation or optic radiation passes through retrolentiform part. Due to involvement of these fibers, there is visual disturbance. There are visual defects. Due to involvement of auditory radiation, the fibers of inferior thalamic radiation passes through sublentiform part. Due to involvement of these fibers, there are auditory defects. So due to involvement of sublentiform and retrolentiform parts, there are visual and auditory defects. As the tracts passing through the internal capsule are closely packed, even a small lesion can cause extensive paralysis. As the tracts passing through the internal capsule are closely packed, even a small lesion can cause extensive paralysis. This is very important. There may be small lesion in the internal capsule, but it leads to extensive paralysis. Sensations can also be lost. Reflexes are exaggerated as in a typical upper motor neuron paralysis. When the Charcot's artery is involved, it affects the posterior limb, hence it leads to spastic paralysis of opposite half of the body due to involvement of pyramidal and extrapyramidal fibers at the upper limb trunk and lower limb on the opposite side. When there is involvement of recurrent artery of Huebner, it causes paralysis of face and upper limb muscles on the opposite side. When there is anterior caudal artery involvement, it leads to visual and auditory defects.